All right, any questions from the first half of Peds? We talked about NICU stuff, kind of basic kinetic differences between little kids and adults and adolescents and all that good stuff. I feel pretty comfortable. You should, because you have a test tomorrow on pediatrics, right? So you should be pretty familiar with a lot of the stuff. Fantastic. We'll reiterate some of this, I'm sure, for you guys, so you at least have a little bit of redundancy in that presentation of information. Anywho, finishing up some of the NICU stuff. So other problems you can run into. So we mentioned, when you have acute respiratory distress syndrome in a premature neonate, what's usually the cause of that? Yeah, they usually don't have enough surfactant. So we talked about giving them surfactant, helping to kind of coat the lungs there and trying to replace that until they can kind of start producing some of their own. What can we give to the mom to help stimulate production? You talked about steroids like betamethasone, things like that. So those are options. Other things that can pop up with some of these NICU kiddos is you can run into apnea. So they can have this apnea prematurity that happens here. There's several kind of components to it. So some of it could be kind of a neurological component where maybe like the brainstem, cerebral cortex isn't quite developed enough yet to kind of have that stimulation of the respiratory drive. There also can be some issues here where they're not that sensitive in changes to CO2, because usually when you have that stimulation to breathe, it's more often a result of buildup of CO2 and not necessarily O2. Did I ever tell you about that game called DSAT? So some of the ER residents that own us in fellowships and the ER residents, they get bored overnight if it's not particularly busy, and so they play a game called DSAT, where basically they'll hook themselves up to a pulse ox so you can hold their breath for the longest and get their O2 sats down the lowest. What you find is it's very difficult to even get down to much below 98, 97% because of the fact that drive for CO2 drive is what stimulates you to breathe. And so very often it was difficult to get your O2 down very, very low at all. So anyway, so again, they may have a kind of a blunting of that effect. That's also what happens with opioids. That's why you get respiratory depressed, is your brain basically gets desensitized to that CO2 and that starts to build up, but they don't have that drive to continue breathing. So that's what the issue with opioids is in a lot of cases. Anyway. So what can we give to, there's some other processes that can happen here. So, the central apnea can be kind of related back to that, diminished maturity of the CNS. There could be some obstructive issues that happen here as well, certainly. And there can be sort of a mixed component here. Anyone know what you could give to a neonate to try to stimulate them to breathe, though? Caffeine, yeah, most of you guys are probably consuming some amount of caffeine. Did you know that caffeine is a respiratory stimulant, right? We used to use this for treatment of asthma back in the day before we had a lot of, better options, things like albuterol and things like that. What is kind of a cousin to caffeine that we talked about for asthma? Yeah, theophylline, right? So they're both classified as methylxanthine. So it kind of goes in and kind of makes sense how caffeine can be kind of a respiratory stimulant. So we'll certainly get to these neonates. Other causes you can see here certainly have other issues like intracranial hemorrhage, you have sepsis. All these can be things that can lead them to have be at risk for apnea. But specifically getting into ways to prevent that, we can do things like avoid sudden changes in temperatures. Usually they're under some sort of a heat lamp to try to help prevent and kind of regulate their temperature a little better. Make sure their airway is clear and make sure you maintain nasal patency, things like that. Sometimes we'll even use continuous pressure ventilations like CPAP, things like that. And we'll talk about the pharmacological management because that's, again, what we're kind of mainly focused on in this class. So we can do caffeine. Caffeine, basically, it's, you don't just like crack open a Monster and kind of feed it to them. Would not be super appropriate. I've tried to do it before and they kind of poo-pooed that idea. But basically, we can either use PO or we can use IV caffeine. So we have basically formulations that are in solution. We can give them a loading dose, essentially. Caffeine has a little bit longer of a half-life, so we want to make sure we get to steady state pretty quickly. So we do that loading dose initially. So you can see here the dose is a lot higher than what your normal maintenance dose is going to be. Again, doses specifically are not going to be tested on, but just know that, again, this is what we're mainly using for apnea of prematurity here. So we'll give that maintenance dose, usually daily, until we kind of have started to mature a little bit more. Once they kind of, eventually you can kind of try to titrate off of this and see how they respond. If they still have those apneic episodes, then you can restart it for them again. But again, it's one of those things where it's nice because there's a nice kind of long half-life where we're kind of taper down this dose over time to where even, as you're starting to wean them off of that, they still have that effect around for a while until make sure they can really kind of breathe on their own. Okay, so any questions on the NICU kiddos? Talked about sepsis, surfactant, caffeine. Those are kind of the main things we kind of run into most frequently for those patients. All right, continuing on, cystic fibrosis. What is cystic fibrosis? Too much mucus? Problem with chloride, absolutely. So it's a genetic condition, right? They have an issue with their chloride transduction through certain channels. And so you mentioned too much mucus, not necessarily too much mucus, but what is the property of the mucus? Super thick. Anyone know another name for that? Viscous, another name? Very tenacious. I like that. That's a very kind of a nice descriptor word for it. Like very tenacious sort of mucus is very thick, very viscous. Absolutely, all these are really good words to describe that. And so where does that mucus get plugged up at? Airways is one. Digestive system would be another big one. Anywhere else? Those are two of the big ones, but we'll look at some other metabolic complications that happen from different areas kind of being plugged up a little. So. But anywho, and we see this quite a bit over at Nemours. So if you work in, especially on the inpatient side of pediatrics, or if you work in the pulmonary, in a pulmonary group, like you'll definitely see some of these patients come along. The nice thing about this is that we now have better therapies for it. We all have better things like antibiotic regimens, because one of the big things you're going to run into for these patients is that infectious disease is a huge issue, right? Because again, normally we don't have a lot of respiratory infections, because why? We can clear all that gunk out of our lungs, right? We have this nice ciliated epithelia. They can move that mucus up, and we can get rid of that. These patients are not going to have that benefit, and so you're going to find that they will be colonized with some of the most virulent, just resistant bacteria you've ever seen. So, like, if you ever look at a CF respiratory culture, you're going to find all kinds of like bugs you've never even heard of before. Bugs that are resistant to pretty much everything, and that's a frequent cause for them to be admitted in a lot of cases. And again, looking at who's more likely to be affected by this, you see Caucasians tend to be a little bit more disproportionately affected by this, or more likely to be carrying those mutations there. And again, it's autosomal recessive, so you need to have it coming from both parents in order to actually have CF there. And again, this is one of the things we normally test for in basically all infants as they're born. You guys know what happens to the skin in a CF patient? Is it their sweat? So back before we had ways to actually test for the genes to see if they had CF or not, they would have basically this frosting of the skin, because all that salt that would basically be kind of deposited there, because that issue where sodium could be moved along, but chloride could not. So it had this kind of frosting. If you lick them, they'd be kind of salty. Again, I don't recommend licking babies frequently. It's a bad idea. It's kind of weird. Anywho, so again, there's different mutations, but the most common ones is Delta 5 FO8 mutation. You're going to find that most CF patients you deal with probably have this mutation, and they'll be tested for this in a lot of cases. But certainly there are many more mutations are out there. This just happens to be the most common one. So the problem here is the CFTR. This is cystic fibrosis transport receptor or protein, basically, are unable to transport chloride through this. And so we're going to find this is going to be affecting all sort of secretory organs. So you're going to find it's going to be affecting epithelial cells, the airways, the biliary tree, intestines, the vas deferens. So again, that's another place where things can kind of get clogged up. So you're going to see a lot of infertility associated with CF. The sweat ducts, pancreatic ducts are another big thing as well. So we're going to find that diabetes is a common thing that develops in these patients, and we'll look at why that is a little bit later on. But basically, they're having kind of inappropriate fluid secretion, because we mentioned wherever salt goes, what goes along with it? Water, right? So again, if you have an impairment where you're not moving those ions appropriately, salt or water cannot go along with it, and that's why these things, the mucus gets so viscous and so kind of thick for those patients. So again, you're going to find they precipitate out. It's going to obstruct those ducts, and that's where we're having a lot of these issues here. So for instance, we have issues where, say for instance, the pancreas is being blocked up. What do you think might be a problem with that? So yeah, so insulin would be a problem, but not necessarily from the secretory standpoint. What's the other main thing that the pancreas is secreting? Digestive enzymes, right? So if that is blocked up, what happens to those digestive enzymes? They still digest, but at that point, what do they digest? The pancreas, right? So that kills off a lot of your beta cells, and so you see things like insulin depletion. The other thing is like what happens to all that food in their GI tract? Doesn't get digested, right? So we're going to see things that help to replace a lot of the things that the patient's not able to secrete on their own. So a lot of the pharmacotherapy, a lot of these are new drugs we haven't talked about before, but their main goal is to replace what the patient cannot secrete on their own in a lot of these cases. So again, usually you're going to find these abnormalities in the epithelial cell electrolyte permeability. So I mentioned less sodium and less chloride permeability due to that. Again, that's how you can have that kind of frosting of the skin where you have an impaired ability to kind of regulate that. And so again, sweating can be an issue for them as well. Anyway, okay, so lung problems. So we're going to go by organ system for these patients. And again, I only talk about this. You may not see this, we're dealing with a lot of adult patients, but as they are getting older, as we get better therapy for them, you're going to find some of these patients are growing into adulthood more so than what they were previously, which is a good thing. So you're more likely to find some of these patients, even if you don't work with pediatrics specifically. But you're going to find that most of the morbidity and mortality comes from the lung complications of CF. And so we have a lot of patients that end up dying from this eventually due to lung complications, mostly of an infectious nature, most often. But anywho, what can happen here is when you have these obstruction of the airways, you have really kind of thickened, dehydrated sort of mucus there, you can end up developing these infections because that mucus just isn't moving anywhere. So it's kind of a nice breeding ground for bacteria to start to develop there. Not only that, but you have a lot of inflammation kind of coming in to try to deal with that, and you're going to have some destruction of the tissues, just like we see with like autoimmune conditions, to a lesser degree, but kind of a similar process that happens there. So a lot of bronchiectasis that can develop, and you have basically progressive obstruction of the airways, right? So they can look kind of like an asthmatic sort of patient because they're basically just blocked up, and so we're going to find some things we can do to try to deal with that. So you find that mucociliary transport's not going to be working very well. All those airways are going to be obstructed there, and so again, you can see things like chronic air trapping, have atelectasis that can develop here, and so we're going to have a lot of inflammation, you're going to have abnormal lung function, and you're going to have a lot of microbial growth. Okay, what type of bugs do you think you might see for these type of patients? Yeah, Pseudomonas is going to be a big one, right? Because again, normal healthy individuals don't get Pseudomonas, right? Normally we can clear that out of the airway, or we can have an appropriate immune system response to that. But Pseudomonas is going to be a big thing. What else could you see? All the normal airway stuff, right? So again, you think about like pneumonias, like all of that can still be there, right? So that can still be causing issues such as strep pneumo, H flu, a lot of atypicals like mycoplasma. So these are all things that can be potentially causative organisms. We're going to find that they have an even extended spectrum of bugs that can be affecting these CF patients. Things like Stenotrophomonas multifida, things like Burkholderia cepacia, things that I cannot even begin to pronounce because they are like yay long. There's lots of X's and Z's all like right next to each other. Very difficult consonant groupings. However, they get colonized with these bugs and they can be very difficult to treat. We'll look more at that in detail. So again, just kind of looking at a normal sort of healthy set of lungs versus a kind of chronically blocked up mucus filled sort of lungs in a CF patient, you can kind of see where it's just a nice breeding ground for inflammation and a lot of bacterial growth. So, and if you imagine here, you have a normal gland that's going to be secreting mucus. It can be, eliminated pretty easily versus having this kind of blocked up mucus plug. That's where I see a lot of these issues that pop up with these patients. Okay. So what we're going to find is that a lot of times what these patients are having is they'll come in with a respiratory infection, and we have to do what we call basically a tune-up for them, where basically we're going to get them kind of under control. They stay in the hospital for long periods of time, like usually several weeks, while they're kind of getting back to their baseline, treating for all these different infectious causes. Because again, they're still having this impairment of the ability to really clear a lot of that mucus and whatnot. But what you're going to find is that they have this kind of chronic infection here. You can have viruses on top of those bacterial infections in a lot of cases. They don't really get a ton of fungal infections. They haven't really run into that too much like you would with like a neutropenic patient, like a hemonc patient or AIDS patient. But they do get a lot of bacteria, very strange bacteria you wouldn't normally see. Right, so looking at the typical organisms here, you're going to be finding that Staph aureus is going to be another potential risk. So something you don't often see. You don't often see a lot of like staph-based pneumonias, but it is going to be a bigger risk for these type of chronically ill patients. You mentioned H flu, Pseudomonas is going to be another big one. You're going to find there's even like kind of different types of Pseudomonas. So you guys ever heard of like a mucoid producing Pseudomonas? Basically able to kind of envelop itself in this kind of protective barrier that makes it very difficult for antibacterials to actually penetrate and actually treat that. So when you ever see like mucoid producing Pseudomonas, that's a bad news. That means it's kind of a late stage complication. They're developing further, even more resistant Pseudomonas than they would otherwise. We mentioned Burkholderia, mentioned Stenotrophomonas here, Aspergillus potentially. I don't see it too often, but it could be a risk there from a fungal standpoint. But again, just lots of different types of bugs you may not see in otherwise healthy patients. So again, I mentioned that Pseudomonas aeruginosa has two main phenotypes, a non-mucoid, but that mucoid producing basically has an alginate barrier there. And we mentioned alginate, sodium alginate before. Where do we talk about that? Started out like for GI stuff or GERD. Remember how that formed with interacted with sodium bicarbonate. It was able to kind of help to form a nice coating on the stomach. Similar thing here, where the Pseudomonas is protecting itself by having this barrier that makes it very difficult for those antibiotics to really penetrate. And they also inhibit things like phagocytosis by the white cells and things like that. And so typically you're going to see kind of an associated decline in function, pulmonary function over time when you have this kind of more virulent form of Pseudomonas. All right, so if they're having these kind of acute exacerbations, these kind of acute infections that are happening here, you're going to find that they'll have kind of low-grade, kind of chronic lung function issues that will kind of slowly progress and get worse over time, but they will have these kind of symptomatic acute episodes that pop up, and this is most often what they're kind of coming into the hospital for in a lot of cases. You'll see things like a lot of dyspnea, cough, occasionally see some fever and leukocytosis, but when they come in, they're going to basically need 2 to 3 weeks or so what we call a tune-up therapy, where we're going to be culturing them, kind of finding out what they're growing. This is another case where it's super, super important to look at past cultures. And why do you think that's important? Yeah, you want to look for resistance. You want to see what they've been on previously to know what you want to put them on going forward. So for instance, if they had, say, what's a good anti-pseudomonal antibiotic? Or cefepime. Cefepime is a very good anti-pseudomonal cephalosporin, right? Remember what generation? Fourth generation, right? So again, if they had Pseudomonas that was previously shown to be resistant to cefepime, and they come into the hospital this time, and I don't review those past sensitivities, and I start them on cefepime, how likely is that to be effective? Unlikely. It's unlikely that they would have changed, and all of a sudden they have more susceptible Pseudomonas than they had the last time. These things typically only move to get more and more resistant. So this is why it's really important to look at past cultures, make sure you can evaluate those. So basically what we're trying to do is, and we're never going to completely eradicate all the bacteria out of these patients' lungs. That's never going to be possible. We can try to kind of get them back to kind of their baseline, try to suppress those infecting organisms, and kind of restore that balance there, where they kind of can be go home and kind of go into more of a maintenance phase for a period of time. But again, you need to treat this aggressively. You need to make sure you're monitoring, and this is where things like where we can do a lot of therapeutic drug monitoring. So for instance, they have a MRSA infection. What are we going to use? Vancomycin. That's one that requires a lot of requires therapeutic drug monitoring. What else is good against Pseudomonas? Fluoroquinolones are an option. What else? Carbapenems are another good one. We might use those. It's another one we do therapeutic drug monitoring on. Aminoglycosides, right? So like your tobramycin, your gentamicin, these are things that are going to require monitoring as well. And we're going to find that because these patients have this altered ability or that altered function of that CFTR gene, that transporter, you're going to find that they also have altered volumes of distributions. We'll look at that a little bit later as well, because that will affect how they're handling these drugs from a kinetic standpoint.
Do you mainly see the mucoid Pseudomonas with CF patients?
That's the main one, because again, they're just having this like chronic, they get this colonization that occurs where you're never really able to eradicate that Pseudomonas, so then over time it will develop into a mucoid strain, and then once it's there, it's kind of there, unfortunately. It's very difficult to get rid of that. Also, maybe some of these patients do go on to get lung transplants. Like sometimes their lungs just get so bad that they're eventually going to die from these one of these infections, And so I've seen a few that actually go and get lung transplants, and they do really well after that. Do very, very well. But again, it can be difficult to get on that wait list and actually get that done. But anywho, so looking from a gastrointestinal standpoint, again, we'll get into specific therapies a little bit later on, but looking at this, you normally will find that CF patients, 15-20% of them have that meconium ileus, because again, it makes sense because they're not really, their GI tracts getting blocked up just like everything else is. But you can notice things like emesis and abdominals, distension, things like that. Usually it's going to appear pretty early on in life, and that can kind of cue in that, hey, maybe this is something that's going on with these patients. But we're going to see, and older patients are also going to have dealing with a lot of cramping, abdominal pain, abdominal distension associated with this. So we'll find some therapies that can kind of help with trying to get their GI tract back into kind of a normal level. So you're also going to find they have a lot of esophagitis and bile reflux that can come about from this. You'll find that because of the issue of them not really being able to, their pancreas not really having that good exocrine function, like we mentioned, those digestive enzymes, that malnourishment can be a big issue. A lot of times these patients have really kind of high caloric requirements, because again, when you're in an inflammatory state, what does your metabolism normally do? gets ramped up, right? So they're usually in a very high caloric kind of need, and they have an impaired ability to really absorb a lot of those calories. So they get typically malnourished in a lot of cases if they're not kind of managed appropriately. And things like rectal prolapse that happens here. You're going to find that they can't absorb a lot of fat-soluble vitamins. So A, D, E, and K are the main fat-soluble vitamins that we worry about. So we're going to find that we need to supplement them for that. So lots of issues that can come about from this. So again, these are all things we're having to replace for these patients. And as you can imagine already, that their med list is starting to get pretty long. And so these patients, their med list probably rival that of like most 80-year-old patients where they're on 15 different meds. You can definitely see that very easily for some of these CF patients. So one of the things we'll see here is they can have this biliary cirrhosis that happens, somewhat rarely, but they'll definitely have this biliary sludging that can happen there because, again, everything usually gets more viscous for these patients. And so one of the things we can actually do is give them this ursodeoxycholic acid, otherwise known as ursodiol or Actigol. So I think gallbladder, I think Actigol, I think of this as a replacement for that. And so basically this can help to kind of replace the normal bile salts that they've been releasing. And what do normally the bile salts do to the food we're ingesting? Help them emulsify fats, help them get to be a little bit more easily absorbed. This is basically doing the same thing. What do you think about that prefix here, this urso? What animal do you think this comes from? It comes from bear bile, so it's actually another interesting animal source for this. I don't know if they actually do this synthetically anymore, but the original source was bears. So bears beats Battlestar Galactica, right? Yeah. Which is germane to your prescription assignment. I don't want you to read that. Anyway. Also, you're going to see that they can have issues with, esophageal varices. They can have ascites, icterus developing from this. So again, this is a good replacement drug that we can administer to them to try to replace that function there. And then they can also manifest things like chronic appendicitis. So all these kind of different issues may not show up in every CF patient, but they are at risk. All right, so pancreas is going to be another big thing here, where again, these patients are going to have some degree of pancreatic insufficiency, and again, it depends just on their mutation, how severe they are. But you're going to find that this disease is going to be kind of progressive throughout life, because again, if they have the ability to express those exocrine secretions, it's going to stay within the pancreas, and you're going to have this autodigestion that occurs over time. And so eventually, you're going to see things like decreased function of or decreased ability to release insulin. You're going to find diabetes associated with this, so it's not uncommon to find these patients on insulin as well. But again, you're going to have a lot of malabsorption, a lot of kind of like these greasy, bulky sort of stools, because again, they're not really able to digest those fats and those carbohydrates and those proteins like they should otherwise normally be able to do. And you'll notice things like growth retardation, you'll have stunted growth, failure to thrive, things like that. They can occur pretty commonly with these patients. As I mentioned, CF-related diabetes as well. Now, for a patient like this, do you think they would need something like metformin?
No.
Why not?
Because you're not producing that much insulin.
Right, so their main function is they're not producing insulin. It's not necessarily, this is more like a type 1 diabetes sort of situation than something like type 2 where they have insulin resistance. They don't really have insulin resistance in a lot of cases, right? Would something like a sulfonylurea work very well for these patients? No, right, because sulfonylureas, right, they stimulate release of insulin from the pancreas. Not really going to fix your problem here, right, because again, it's not going to get rid of all those enzymes digesting those beta cells. So again, think about the way these drugs are working. Think what makes sense for these different patients. And again, the main thing it's going to be able to replace that is insulin, right? That's going to be the main thing we're using for these patients. So hyperglycemia occurs pretty frequently, especially after the first decade there. And again, this makes sense because as they're getting more and more progressive, more and more pancreatic functions being lost there, you're going to find this is especially more prevalent in patients who have that delta F508 homozygote. So again, they tend to be much more likely to manifest this. And again, it can be kind of shades of gray in a lot of cases, depending on what mutation they have. But this is the more common one, as we mentioned. But again, you may find some degree of insulin resistance, but mainly the big thing is going to be impaired insulin secretion in those cases. Why you need to replace it with more insulin. Again, they don't typically get like a ketoacidosis. They're not really as severely insulin deficient as you would see with like a typical type 1 patient, but so they don't really develop DKA very often. However, they can develop this kind of more chronic kind of hyperglycemia. And who likes a lot of sugar floating around the blood? Bacteria, right? So that's another thing where you're worried about getting the sugars under control, because again, that helps promote further growth of the bacteria. All right, looking at genitourinary issues here, you're normally going to find sexual development is going to be delayed for these patients. Oftentimes they're going to have issues with development of the male sex organs, especially during puberty. You can notice infertility is going to be a big thing that happens here. Adolescent females can have secondary amenorrheas that develop. Usually their fertility rate is going to be somewhat diminished, right? And again, there's concern about things about passing on those genes because obviously if they have it, then they're going to be homozygous for it, right? So again, there's concern they pass it on to the child, they become a carrier, or depending on who their mate is, they may potentially have a child with CF. All right, so we mentioned the sweat glands. Typically, you're going to find they have a lot of salt that's going to be lost in the sweat. So you can notice salt depletion, which can, especially during cases like gastroenteritis, having a lot of vomiting, or if they're having during the warm weather, especially we're coming up on spring and summertime, this can be more likely to happen in those patients. And so they'll have this hypochloremic alkalosis that occurs here, and that's how they get that frosting of the skin. It's kind of salty tasting. So that's what they used to do back in the day, back when we used to use cocaine and heroin to treat everything. They'd kind of lick these babies and see if they have salty skin, and that was kind of their key that it was probably CF. I don't know if that was exactly the same time frame, but in my mind, everything in the past is like cocaine and heroin for everything, and then salty babies, and that's around the same time. I'm not very good at history, by the way. Anyway, all right, so again, once we're kind of assess these patients, when we kind of have the diagnosis here, obviously education is super, super important. They are going to require a lot of visits. They're going to be coming back to the clinics, coming into the hospital very, very frequently, so they're going to be what you call your frequent flyers. One of the big things to do, especially the first diagnosis, is get a sputum sample and try to culture that out and find out what sort of bugs they already have. They're kind of colonizing them to determine what the susceptibilities are going to be. We'll talk about antibiotic selection a little bit later. Again, oral hydration is going to be really important, especially during cases of acute gastroenteritis, in case of warm weather, things like that. They need to make sure they stay hydrated. And that can help to kind of prevent an exacerbation from happening in the first place. And what you'll normally find in a lot of these patients when they're coming in for an acute lung exacerbation, they're typically very well dehydrated. And so that's actually a really important point, because when we're looking at therapeutic drug monitoring, if you were to say, for instance, have a drug that is hydrophilic, say like gentamicin, and have a very dehydrated patient, what do you think that does to the volume distribution? Should decrease, right? Because again, everything's going to be more concentrated into the blood. So if I were to measure a level there, what do you think the level would be? Too high or too low? Too high, right? Because the drug is too concentrated at that point. So I would falsely evaluate that to say, well, the drug is too high, they're not clearing it well, I need to go ahead and reduce my dose or reduce how frequently I'm giving it. Not actually the case. What they need is good rehydration, right? So again, this same thing goes with talking about fluid hydration earlier. We mentioned what's a good fluid bolus, an IV bolus for these patients. Same as any other patient, right? The 20 mLs per kilo is a good dose to start with, and then you do that 4-2-1 rule to get what their maintenance rates are, because typically their kidneys are generally pretty good for the most part, and in fact they may actually have some increased clearance of a lot of these drugs. But get them hydrated, get them kind of tanked up, and then you kind of start to evaluate drug levels a little bit more reliably. So those are things to consider when you have these patients coming in for an exacerbation. All right, so our goal here is we like to kind of prevent lung function deterioration, because again, this is what is most often going to kill these patients over the long run, and also prevent poor nutrition. So we mentioned some things we can give to replace that. We'll go into more detail on that. And of course, you want to be make sure you're checking their PFTs, making sure you're looking for that delta over time to kind of notice, okay, are things kind of progressing more quickly than I would like? What can I change about their regimen to kind of correct this? All right. So again, one of the things we can do from the pulmonary standpoint, we'd like to clear their secretions and control the infection. So what are some ways we can get rid of those secretions? What do you think? Yeah, okay, so mucolytic. So mucolytic means what? It means to start to break up the mucus, right? So we mentioned that very thick, tenacious sort of mucus. Like we want to break that up, right? So we'll talk about mucolytic therapy in a little bit. What else can we do? Yeah, so the physiotherapy is another term for that. So basically we'll talk about physiotherapy, and we'll actually talk about the ordering of these things, and that can actually be really important when you're talking about the different medications and making sure they're getting to their site of action to work effectively. So we'll talk about chest physiotherapy. Will be an important thing with helping them to kind of get rid of the mucus. Some inhalational therapy. So we'll talk about the drugs you can use for that, and then antibiotics, right? So these are kind of the big components of their pulmonary regimen that we want to make sure we're including, and we want to make sure we're ordering it correctly. So for instance, if I want to give an antibiotic to these patients, do I want to give it to them when their lungs are full of gunk, or do I want to try to get rid of the gunk first? probably want to get rid of the gunk first, right? Kind of get rid of as much crap as you can, and then try to give them the inhaled antibiotics. We'll talk about which ones we use in a little bit, and then that will get much more to the site of action. They'll be able to get there and penetrate more of those bacteria, right? So again, these are things we'll kind of be thinking of, and why these regimens will kind of be ordered out in a certain way, as we'll see. So talking about chest physiotherapy, we're going to find that basically this kind of this postural drainage along with chest percussion, this can be done either manually or it can be done with like they have like vests that the patient can wear that will actually help to try to kind of percuss the chest and try to unlock some of that mucus in different areas. This will try to clear that from kind of the larger airways. You're going to find that a lot of patients do not stick with this. They are not as compliant as they should be because you need to do it frequently, right? Because they're always producing more mucus, anywhere between 1 to 4 times a day. And a lot of times, children, adolescents, they don't want to stick around and have to do this because it's kind of boring. They have to, stop whatever they're doing if they're playing outside or whatever to come in and do this. So again, compliance is not always the best with this. And then oftentimes this is what kind of leads them to have an exacerbation where they're just kind of building up this junk over time. They're not doing their physiotherapy like they should, and they have to come in and see us. And so again, mentioned there's either chest vests that they can do this or they do manual CPT. All right, so another big thing we're going to talk about is aerosolized antibiotics. So again, what's the benefit of using an aerosolized antibiotic, do you think? Right, so very high concentrations of drug are right at the source, right? We know this lung is a source of infection, so let's get as high concentrations as we can there. And then what about the concentrations elsewhere? Pretty minimal, right? So we know as an inhaled form, as we think about, inhaled steroids, right? They help to spare a lot of the rest of the body of the effects of corticosteroids by having high concentrations right there in the lungs. Same thing goes for these aerosolized antibiotics. We have to get high concentrations right there. And so we know that we see, with studies that we can reduce their symptoms, avoid hospitalizations by doing this, and improve function of the lungs over time. And so these are not used in place of IV antibiotics, but can sometimes be used as an adjuvant or used as an adjunctive sort of agent to help, kind of supplement the effect of other systemic antibiotics. So we'll use things like basically when they come in to the hospital for like an exacerbation, they'll get IV antibiotics in addition to aerosolized antibiotics. Usually when they go home, they'll stay on these aerosolized antibiotics because again, it's very difficult to send a patient home on IV therapy. Not impossible, but it's very difficult and you don't like to do that. It's kind of a big hit to their quality of life. But main things we're going to use are going to be things like tobramycin, which actually has a formulation that is made for this called Toby. So if you ever see the Toby, which again goes back to the Office references, right? Anyone? Yeah. All right. Anyway, so tobramycin can be used as an aerosolized antibiotic, but other aminoglycosides will work very well here as well. And notice, what are these going to be targeting from a bug standpoint? Pseudomonas, and what else? Just broadly, gram negatives, right? Gram negatives, Pseudomonas, those are the big things we're focused on when we're using these aerosolized aminoglycosides, right? We have things like cholestyramine or colistin. This is going to be more akin to polymyxin, sort of those kind of really kind of harsh antibiotics we don't like to use from an IV standpoint. If you guys remember when we talked about that back in the ID section. However, this is good to use in a kind of a localized just applied right to the lungs, because again, you miss a lot of the systemic side effects, neurotoxicity, renal toxicity, things like that. And then we could even use something like ceftazidime. And ceftazidime is what type of antibiotic? The cephalosporin. Remember what generation? It's the 3rd generation, but why don't we like to use it? Resistance, right? Resistance to Pseudomonas, because again, when you think cephalosporins, the most common cephalosporins have an anti-pseudomonal activity. You think cefepime, and you think Fortaz or ceftazidime. We don't like ceftazidime in most patients because you can end up seeing a lot of resistance to develop to that from the pseudomonal standpoint. However, when I'm giving super high concentrations, guess what? You can overcome that resistance, right? Because we mentioned that resistance is kind of determined by those minimum inhibitory concentrations. Remember what that is? What's that MIC? What does that mean? It's that level you have to get above in order to actually inhibit the bacterial growth, right? So again, if I am giving a systemic antibiotic and I cannot get above or even close to that MIC, it's going to be resistant, right? It's going to, the new bugs are going to say, oh, this is not high enough concentrations, I can continue to grow, no problem. However, when I'm using aerosolized antibiotics and get very high concentrations, you can go definitely above that MIC, right? So that's where ceftaz can be used as an inhaled form. Even though you may find that systemically it may not be a great drug, you may be able to get some benefit using it from an aerosolized standpoint. Because again, it all goes back to concentration. You can overcome resistance by driving with the concentration. However, I can't do that systemically because then you see toxicity develop, right? So these are things to consider. Okay, So those are kind of the main antibiotics you use from an inhaled standpoint. Next up, we have a drug called Pulmozyme or Dornase alpha, and this is going to be one of the first mucolytics that we're going to see being used for these patients. And so basically, this is a drug. It's an enzyme essentially. So it's a protein-based product. So again, what do you think about the cost of protein-based products? Expensive. These are very expensive drugs. A lot of these kids end up being like on Medicaid, so a lot of this is covered in a lot of cases. So cost is not as big of a standpoint, big of a hassle. Usually they can get a lot of their medications covered, which is a benefit to them. Anyway, this is actually a DNA enzyme that will actually cleave the DNA of the nuclei, developing these neutrophils that are developing within the lungs. So basically, when you have this nice thick mucus, you have a lot of invasion of white blood cells and neutrophils and things like that due to causing that inflammation. By coming in and kind of cleaving that DNA, it helps to kind of break up some of that mucus there, helps to break up, decrease the viscosity of the mucus, and it makes it more easy for them to clear that sputum, which is beneficial. Seem to kind of decrease or help to improve pulmonary function and more mild to moderate disease, and you'll probably see them stay on this for usually the duration of their disease there. Definitely shown to decrease exacerbations, which is another good thing. Again, if they don't stick with their inhaled therapy, this is usually when we end up seeing them come in for exacerbations. It's really important to educate them to be compliant with this as best they can. So let's see. Other things you can do to help break up that saline, one thing you can try to do is try to rehydrate that mucus to try to make it more thin, make it more easily able to be cleared. And so this is where we can use hypertonic saline. When I mention hypertonic, what does that mean? Higher concentration. What's isotonic saline? You guys remember? It's normal saline. Remember the percentage?
0.9.
Yeah, 0.9% is considered normal saline. It's isotonic to the blood. This is hypertonic saline. It's 7%, right? So this is a much more concentrated form of sodium chloride. But you can actually use this, and again, by drawing more of that, putting more salt into the mucus there, you can imagine it's drawing more water into it, helping to start break it up a little bit. So again, you may see some patients just on hypertonic saline. You may see them just on Dornase, or they might be on a combination of the two, right? So you can utilize both of these to help really kind of break up that mucus and make it more easily able to be cleared. You know what I mean when I say the rheologic properties of a fluid? Basically goes back to how easy it is to flow. So again, something that has poor rheologic properties, it does not flow very well, so that mucus that they're producing is not great. However, when I'm able to give hypertonic saline, it makes it more easily able to flow, more easily able to clear. So that's one thing, if you hear that term, that's what it's kind of referring back to.
So viscosity.
Basically the viscosity, yeah. The less viscous it is, the better flow it has. Yeah, basically that's another good way to put it there. Yep. Okay. So again, looking at, we'll talk about one other drug you can use in mucolytic later. I'll probably usually save it to talk about in the toxicology section, but anyone know what you use to treat acetaminophen overdose? Mucomyst, a drug called Mucomyst. N-acetylcysteine is the drug. We'll talk about that later. However, it is also a mucolytic, and so there's actually an inhaled form. We use the IV form. Basically, we just put it into a nebulizer, and you can inhale that. One of the big things to know about Mucomyst is it is high in sulfur content. That's why it helps the liver to detoxify things like acetaminophen. Anyone know what things with high sulfur content smell like? Rotten eggs, right? So my first job as an intern in a hospital pharmacy, they said like, well, you're the new guy, so you get to take these big vials of acetylcysteine and you get to kind of put them in these little 3 ml aliquots. Remember aliquots? Take them from a big vial, put them into a little small vial, and then you kind of crimp them up, so that way the respiratory therapist could use these for patients who need better mucus clearance. And so I get to smell that basically all summer. I was just like, this is the worst job ever. Why do I want to do this? And I got desensitized to it eventually after doing tox for so long. I can't really even smell anymore. It just smells like regular eggs now, which is weird. But anyway, so we'll talk about that drug later. Just know that as another drug you can potentially use as a mucolytic. It'll help to kind of clear the secretions a little bit easier. Again, it all depends on the pulmonologist, what they kind of how they assess the patient, decide what they want to use for them. So looking at their pulmonary exacerbations, need to treat them pretty aggressively, right? Because these patients can tend to decompensate pretty quickly. They look good for a while and then they kind of decompensate very quickly all at once. And you're going to notice that treatment usually for these exacerbations 2 or more weeks, right? So when they come in, they're at least going to be there for 2 weeks, if not more, based on how they're kind of responding, how their pulmonary function tests are doing. And so we're going to use pretty maximal doses of antibiotics because, again, looking at places that are easy or hard to penetrate, the lungs, how easy are those for antibiotics to penetrate? Not very, right? So again, not very easy for drugs to penetrate the lungs. That's why we try to require higher doses of a lot of antibiotics. And the other thing is these guys are even harder to penetrate because, again, they're full of all this nice viscous mucus. It's very difficult to get in there and actually attack those bacteria. So we got to use pretty maximal doses, go pretty hardcore with that. And we're going to see that antibiotic therapy is going to be the biggest thing for them. So we're going to get at least 2 weeks of therapy again, based on cultures, based on past sensitivities. And we'll talk about some good ones to use kind of upfront for these patients. So again, just some of the things you can see when they're kind of coming in here is, obviously a lot of cough and sputum production, dyspnea, weight loss associated with this is another big thing. And certainly you'll find, their chest x-rays are just totally gunked up, kind of full of stuff. Maybe some atelectasis there, but certainly these are things you'll most often see with patients coming in for these exacerbations. Now, looking at treatment, so say for instance you wanted to try to prevent an admission, you could use some oral antibiotics, and so some of your regimen would include things like coverage for Staph aureus, because again, normally when you're covering for like a pneumonia, do you cover for Staph? Not typically, right? You cover for strep pneumo usually, but you do not normally cover for Staph in an otherwise healthy patient. However, you do need to do that here. So again, if you were, they don't have any documented history of MRSA, you could use something like an anti-staphylococcal penicillin, right? So this would be for MSSA. You guys remember when we talked about the differentiation there? All right, so use things like dicloxacillin, cephalexin has some coverage here, clindamycin, which is really good against most gram positives, right? Gram positives and anaerobes is a big clinda coverage there. And then looking at things like, possibly, augmentin, adding on a beta-lactamase inhibitor there. Even some macrolides will cover this as well. So we'll look at zithromycin a little bit later. We use that for a different function in CF patients, which we'll allude to here in a minute. Looking at coverage for things like H flu, again, look at their vaccination status, see if they might be a bigger risk for that. Things like amoxicillin or augmentin, good coverage for that, or using something like a second or third generation cephalosporin. Anyone know a good oral third generation cephalosporin? Ceftriaxone is only parenteral, but that would be a good option if we're going to do IV. Ceftonir, Omnicef or Ceftonir is a good third generation oral option. So again, that would be one you may prescribe for them. And then for Pseudomonas, again, we don't have a ton of good options from an oral standpoint. We can use things like ciprofloxacin or Cipro, but the other big thing is going to be for the inhaled tobramycin. Usually the most common one we're going to do for those patients. Right, so these are all things you do if you try to prevent an admission. A lot of times you may not be able to do that. You may need to bring them in for parenteral therapy. So looking at IV antibiotics, typically you want to start off, remember we don't typically double cover bacteria. However, what's the exception to that? Pseudomonas, right? Pseudomonas aeruginosa is the one drug bug you typically double cover for in most patients, especially if they're worried about pneumonias, things like that. So again, treat PA, not physician's assistants, but Pseudomonas aeruginosa. You guys just happen to share the same acronym there. However, you want to do a minimum of 2 antibiotics. So typically, what we'll do is an aminoglycoside, so gentamicin, tobramycin. What's the third one? Amikacin is the third aminoglycoside most commonly used. And we'll use that in combination with the anti-pseudomonal beta-lactam. So you get good synergy there. So I say anti-pseudomonal beta-lactam, what are my options? Zosyn, right? So you use piperacillin tazobactam is a good one. What else? So it's a penicillin. Mentioned from the cephalosporins camp. Cefepime is the other big one, right? That's a good one. What else? What about our carbapenems? There's imipenem, meropenem. Good, those are the big ones. So you use probably meropenem more often than imipenem. There's one other one that, well, you guys probably won't remember. Aztreonam. Remember Aztreonam? That was one that only had coverage against gram negatives, but did have pseudomonal coverage, right? So those are kind of the more common ones you're going to run into. Probably cefepime, probably Zosyn. Certainly fluoroquinolones could be used as an option if they had a true allergy, they couldn't really receive it. But we like to use aminoglycoside plus a beta-lactam. Those are kind of our go-to combinations. So again, they come in and they already showed documented resistance to cefepime. What do you use instead? And we talked about Zosyn, meropenem, anything like that. So again, you have options there. It's important to look at those resistances first, right? So again, I had a bunch on the list already there, so it was convenient of me to put that, right? Ceftazidime, again, not usually the first line one we go with, but however, if they are showing resistance to most of the other beta-lactams, we may use ceftazidime. There's a few patients we'll keep some vials on hand for when they come in because we know that's what they're going to be susceptible to. And then they may need a third antibiotic for coverage of some of the other things. So like if you're worried about Staph aureus, what could I use from an IV standpoint? Again, these patients are sick enough, they're coming into the inpatient side. So until proven otherwise, I'm going to assume it's MRSA, in which I'm going to use what? Vancomycin, right? If I couldn't use vancomycin, what could I use instead? Clinda, maybe, probably not the first thing I'm going to jump to in a lot of cases. Linazol is another option you may see used as well, right? That's another good backup to MRSA coverage. And then Burkholderia cepacia, actually drug of choice for that is actually going to be Bactrim. So you may see some patients who are on that. Also, we'll cover for things like Stenotrophomonas multifilia. So sulfamethoxazole and what's the other component of Bactrim? Yeah, trimethoprim, right? So sulfamethoxazole, trimethoprim are good for coverage, things like Burkholderia cepacia, things like that. So now for these patients, we mentioned we're going to use typically once daily antibiotics. We want to get, because if you remember, concentration versus time-dependent antibiotics. With concentration-dependent antibiotic, what's the main goal of their levels? We can get them up super high, and then it's okay if it drops down to negligible levels by the end of the dosing interval, right? That's okay because, again, we have that post-antibiotic effect, right? Even though the levels are low, it doesn't mean the bacteria is suddenly actively reproducing. So it's something like aminoglycoside. I want to shoot for a very high level because we mentioned lungs are difficult to penetrate, and so by using a high level or high dose of the drug, you can get high levels there. Hopefully, start to treat some of that Pseudomonas there. And so we'll do things like measuring levels. We can actually calculate out what their elimination constant is. We can figure out what the half-life is for those patients. But the other big thing to do is monitor for other things like volume of distribution because that can be altered based on their fluid status and whatnot. So again, you also know what goals we're shooting for specifically. Just know that that's why we're shooting for big doses of one-time daily antibiotics or aminoglycosides here because it's a concentration of a killer and the lungs are difficult to penetrate. Those are kind of the concepts I want you to kind of understand there, right? Amikacin has a little bit different dosing, but usually Tober and Gent have the same dosing, same levels you're going to be shooting for there. Okay, so we mentioned usually as a result of their malnutrition or their malabsorption of nutrients, you're going to find that they have a different volume of distribution. It could be increased in some cases due to things like lean body mass being lower. You're going to find that the lungs actually act as a reservoir, a place for that drugs to partition into because it's just kind of fluid filled, nice, nasty, thick mucus. And so you can actually find, especially during exacerbation, that volume of distribution goes up pretty high. And so again, if you remember, when you have a higher volume of distribution, what does that do to my dose in order to get the same blood concentration? It has to go up, right? So that's again why I'm using very big doses of those aminoglycosides for those patients because the volume of distribution is altered. So it's one of those cases where you're going to find that you may find normal dosing, but you also can find disease-specific dosing. And so you might see, if you're looking like Lesicomp or something like CF-related exacerbations, they have their own specific dosing there. They typically have pretty good kidney function, so they'll clear the drugs just fine. But again, that can make it very difficult to get high enough drug concentrations. You may need to really drive that dose up pretty high in order to get good serum concentrations there. Starting up, any questions from the first half? Everyone try to lick themselves, see if they have CF? Just to check. Right, you don't need to do drug levels when doing inhaled aminoglycosides. There's not good enough penetration there from a systemic standpoint. It doesn't go for every drug. Now, like certainly, some things get absorbed very well from the lungs that go into systemic circulation. Anyone know of a good maybe drug on the street? Yeah, crack cocaine gets absorbed very well into the bloodstream from the lungs. But in this case, this is something where tobramycin, most often used, does not get absorbed systemically to an appreciable level that we need to monitor levels. That's a very good question. Thank you. Any other questions? All right. So we also wanted to deal with these patients from an inflammatory standpoint. We know this goes into a lot of lung destruction that happens over time as well. We can use things like corticosteroids. This is better for like an acute exacerbation, for more of a kind of a pulse dose sort of thing, similar to what you'd see like a normal asthma exacerbation. Don't normally like to keep them on corticosteroids for very long because again, what's their sugars usually doing anyway? Usually are elevated anyway. This is going to worsen that, right? They're going to see a lot of side effects from this. So we don't want to use corticosteroids more than we have to. However, they could be on things like ibuprofen chronically, right? So you may see that occasionally. But another thing you will see much more commonly due to kind of a relatively lack of side effects is going to be macrolides. So specifically, azithromycin is a very common one. For whatever reason, azithromycin tends to have some anti-inflammatory properties for these patients. And we know that azithromycin, in comparison to, say, some other antibiotics, what's the half-life of it? Long or short? Azithromycin is pretty long, right? We talked about STDs yesterday. You can just give a one-time dose of azithromycin and get like a week's coverage, essentially. So if you ever see someone who's on azithromycin Monday, Wednesday, Friday, chances are they have CF. That's what they're basically are doing it for, is the anti-inflammatory properties. They're not using it as an actual anti-infective for their particular bacteria. Okay, so if you see that, that's what they're doing essentially. Now, if the patient continues to not improve after all these antibiotics you're administering to them, and again, you're going to be getting new cultures to see if there's any kind of new bugs that have shown up or new bugs that are becoming resistant to different antibiotics. You have to consider things like mycobacteria. You have to think about things like TB. You have to think about things like fungal infections and other kind of atypical bugs. So these are things that you may not get in a normal kind of gram-staining culture, but things to consider if they're not improving. Okay, so from a nutrition standpoint, you mentioned that they typically have a pretty high caloric need. So one reason is because they have this increased work of breathing, because again, they have this kind of chronic obstruction that's kind of going on there, and that kind of increased metabolic activity. They're in a very kind of higher inflammatory state than most normal patients. They typically require a lot more calories than other individuals. And again, it's a kind of an issue because they're already kind of bad at absorbing those nutrients anyway. So typically you're going to find that we have to give them special formulas. May not necessarily need ones that have like pre-digested proteins and medium chain triglycerides. That may be necessary for some other patients, but typically as they get older, though, they will require more high protein, high calorie diets, usually normal amounts of fat or so, because again, if they're having kind of poor pancreatic function, you give them a lot of fats, what does that kind of turn into? Greasy, really foul stools, things like that. So you don't want to cause that for these patients. They typically need higher protein requirements and have higher caloric requirements. Those are things to consider from a nutrition standpoint. Now, mentioned with the pancreas, we need to replace those enzymes in a lot of cases. And so what we're going to do is utilize basically a product that contains lipase, protease, and amylase, which we know those are the main exocrine secretions of the pancreas, right? So we're replacing that. And so typically what you're going to find is they will dose these in the units of lipase. So again, this is not in milligrams or micrograms, this is in units they're going to be expressed. And so for instance, we have this like Ultrace MT12 that's going to contain 12,000 units of lipase, and they'll usually have a fixed ratio of lipase to amylase to protease. And so that way, as you increase your dose of lipase, then you'll be able to also increase your protease and amylase as well. Lots of different forms that are out there. Probably the two we use most frequently are Creon and Zenpep. A lot of it just goes back to what kind of dose they require. And so how do you think we would dose these? Like what type of frequency? With meals, right? So we need to give these with meals because that's when they are going to have those products to digest, right? And so you'll frequently see dosing being administered as, say, you're going to take, say, 4 to 5 capsules say Zenpep 12 with meals, and then when else might they be eating? Because again, they have to get a lot of calories in. They probably need lots of snacks, right? So they're gonna need lots of snacks, and so they also will have, say, a lower dose for those kind of lower calorie meals. So you say 4 to 5 capsules with meals, and then you may say, hey, 1 to 2 capsules with snacks. Okay, so those are things that will help to digest that for the patients, and that way they can get good absorption, good nutrition. So. Anything else with these? Now again, with proteins, what do you think the GI tract is going to do to that? The stomach specifically. Right, so again, that low pH, there's that pepsin there. You have to worry about that being affected. You worry about the enzymes being degraded in the stomach. So they actually come usually in some sort of acid protective coating. So if you ever look at these capsules, if you open them up, they have all those little tiny beads in it. And again, that allows you to bypass the stomach. And then once it gets into a more basic solution, it's going to dissolve that, and they can actually interact with the food that's being ingested. So again, one of those other ones you don't want to crush or chew because you end up breaking that coating, and then the protease or the enzymes can be broken down. Okay. So again, usually you're dosing it based on the actual lipase content. So you can say, let's start with 500 units of lipase per kilogram per meal, and then you titrate it to effect, right? So for instance, what might lead you to think you need more enzymes? So what if they're not gaining weight, right? So again, if they're showing they're still being malnourished, that could be one thing. What about the stools, though? If they're not digesting all those fats, guess what? It's going to come out really foul, nasty stools, diarrhea. These are things that would key you into, I probably need to increase the dose of lipase I'm administering to them. That's why we dose them lipase. So again, you can titrate that up until you kind of get to a good happy medium where they're metabolizing that food appropriately, they're absorbing it, they're putting on weight as they normally should. So these are things to consider. Typically, there's kind of an upper cap to how much we can give them, because there's you have this kind of rare side effect, the fibrosing colonopathy that occurs rarely, but it's usually when you have very high doses. I don't know if it's related to the enzymes digesting part of the colon or what it is, but it's one of those things you want to watch out for with really high doses. Now, you can also consider adding on things like, a proton pump inhibitor and H2 antagonist. That can also help to kind of increase the pH of the stomach secretions, can help to increase fat absorption a little bit. So that can maybe one other kind of adjuvant medication that may be on as well. And again, I mentioned that fibrosing colonopathy that can happen there. Other things to supplement, you want to make sure you're definitely supplementing with fat-soluble vitamins. And so we have things, again, fat-soluble vitamins are A, D, E, and K, right? So again, we're going to be supplementing things like Aquadeck. That lets you know, okay, this kind of tells you what kind of vitamins are in there in higher proportions. Even they have ones that are going to be like Source CF, so it's basically a CF formulation. They'll be higher in A, D, E, and K, and it'll be in a formulation that's going to be a little bit easier for them to absorb. So that's another thing to consider supplementing for. For liver disease, we mentioned with that biliary cirrhosis that happens there, we can replace that by giving ursodiol or Actigol, and basically this bear bile is going to help to emulsify those fats like their normal biliary secretion should do. And so we can see that is sometimes, can work up to a point. Some of these patients may actually need liver transplant in the long run. So again, that could be another thing you see. I see it even less commonly than a lung transplant. Again, lung transplant is already pretty rare as it is for some of these patients. So again, maybe something you see, maybe not. All right, so looking at their gastroesophageal reflux is pretty common for these patients. Obviously that can be an issue, especially if they're having kind of micro aspirations of those that refluxate. You can actually see kind of changes in pulmonary function due to that. So again, it's another thing you want to watch out for. Now, one of the things you want to be careful of in trying to deal with those kind of GI secretions is you don't want to give any kind of cholinergic agonist, because when you activate those muscarinic receptors, what does that do to mucus secretion? When you give cholinergic agonist, remember that's going to increase secretions everywhere, and that can actually increase mucus secretions for these patients. You want to, that's not what your goal is for these patients. So typically, sometimes we use H2 blockers, but more often than not, we'll use PPIs because again, those are more potent typically. So omeprazole, lansoprazole, any of those are going to be fine for these patients. Right? Now, one of the new agents, this is actually pretty cool, new drug. It's called Lumicaftor and Ivacaftor. So these are it's combination therapy here. A drug called Orkambi, is the brand name here. And this is actually approved for patients who are homozygous for that F508 deletion, right? So we mentioned that's the most common mutation. So if you have a patient who has that deletion, they're homozygous for it, this drug is labeled specifically for that. And so basically what this actually does is that Lumicaftor is going to improve the conformational stability of the protein. Right, so it's going to help it to work a little bit better, and so it's going to be able to better process and actually traffic mature protein up to the cell surface. It's going to help with the functioning of that, the stability of it, to make sure it actually gets to the cell surface successfully. And then you have the Ivacaftor that actually is going to be potentiating and increasing more chloride release through that transporter there. So kind of by dual mechanisms, we increase the number of proteins that are available at the cell surface, and then we're actually increasing the actual activity of the channel itself, right? So it's going to be one that's better absorbed with fatty food. So again, they typically, so it'll help, if you're administering that around that time frame, you may need a little bit higher fat for these patients anyway, so it will be fine for them. And not a ton of side effects for the most part. We definitely see some better improvements in lung function, better improvements in kind of that mucus clearance that happens there. Now, again, this is a new drug, so we don't have a ton of experience with it like we do with some of these older ones. So some of the things we've seen, same things like menstrual irregularities. It tends to be more common in those patients who are taking oral contraceptives, so it could be one thing to watch out for. Again, not really sure of a mechanism, tends to be what we see. Some dyspnea and chest discomfort, which could be mimicking something like an exacerbation. So again, educate them on that, let them know that's a possibility. And then rarely may have some hepatotoxicity. Okay. So just kind of showing you what the drug is actually doing itself. So again, looking at normal proteins. Normally when it's defective, when you have that F508 deletion, you see it just had the channel kind of sitting there within the cell, not really doing anything. It's not really functional. However, with Orkambi, we're able to get more of those proteins out to the cell surface, more likely to be effective in that case. And so you can kind of see with the in vitro activity of the CFTR, transporters are going to be versus no drug versus someone who actually has the drug on board. It's not going to be approximating that of a normal healthy individual. However, it's a lot better than what it was previously. So again, I'm starting to see more and more patients getting started on this Orkambi being utilized for that. Okay, any questions for CF? Yes, ma'am.
I heard that two people with CF aren't supposed to be around each other. I don't know why that is.
They're not supposed to be around each other?
I think they're not supposed to come in contact with each other. But I don't know why.
Probably related back to infectious reasons, right? So, for instance, certainly there are siblings who have CF together. So I remember we had a set of adolescent females who were sisters. Can't really separate them necessarily, right? But they probably have similar bacterial exposure, right? So they probably are growing the same stuff. And I haven't actually never thought to actually look at their cultures to see if they're actually growing the same stuff and the same resistance patterns. But I venture to say that it's probably pretty similar between the two of them. However, if you have someone with CF who's kind of meets someone new with CF, they can kind of maybe intermingle some of those bacteria and perhaps maybe cause an exacerbation. I've not heard that recommendation specifically. However, that would be my most logical assumption. If there's something else, if you guys know something different, let me know, though.
No, I was just saying I had it explained before.
Yeah. So again, it's just one of those things where it's like when the Spaniards came over and introduced all their cooties over to the Mayans and they all died off. It's kind of the similar feature there, right? So I think. Anywho, I think weird associations in my mind. That's just the first thing that came to my head. Anywho. It'd be interesting if now that all those videos are public, if you guys could like go back and watch the very first videos and kind of compare them to now, just to see my random tangents and like mental decline over the years. It'd be interesting to see. Thank you. Okay, so going on, talking about GI disorders in children. So again, this is a very common thing. I mentioned, probably the most common thing we run into. So especially in the ER at Nemours, your abdominal pain. Guess what they probably are? Constipated. So we get a lot of KUBs, and guess what? They all are FOS, full of stool, not the other thing. We're in children's hospital language, needs to be kept clean, right? Anyway, so again, we see reflux, gastroesophageal reflux is a very common thing.
Excuse me for interrupting.
Okay, so gastroesophageal reflux, very common thing in a lot of these kids, especially in premature infants. They usually have kind of lower esophageal tone is going to be impaired there a little bit, so more likely to see that kind of reflux. So we see a lot of recurrent vomiting for these patients. 50% of infants within the first 3 months of life, they kind of see that. It should decline over time, though. So again, it should get better, but certainly a lot of reflux can happen in these patients. Certainly, my girl Phoebe, she can just go from like happy smiling to blah, just with no effort whatsoever. It's a big mess, but it's one of those things where it happens, right? So kids just kind of get some of that reflux going on, and then the vomiting just kind of happens. However, typically responds spontaneously. There could be some anatomical, pathology there that needs to be corrected with surgery, things like that. However, we're going to kind of just focus on normal kind of routine maintenance medications for that. However, usually it's going to be multifactorial in a lot of the more kind of chronic kids you're going to see with that. However, certainly things like positioning can be important. Looking at things like the food they're intaking can be affecting this. So we're going to see that, a lot of the therapy we're going to use for these kids tends to not really differ that much from adult patients, because again, a lot of it kind of goes, besides some of the anatomical changes that happen for some of these kids, the pathology is not really that different in a lot of cases. So anyway, so obviously our treatment goals here are to eliminate the symptoms. We want to make sure they are able to, again, keep some food down so they can absorb that and kind of grow normally. And if they have any kind of degree of esophagitis, make sure we can heal that and prevent any kind of further complications, right? So our treatment, obviously lifestyle modifications is a big thing here. Dietary modifications, so if there's certain trigger foods that kind of set them off, these are things to watch out for, and make sure they have kind of proper body positioning. Obviously, if you're feeding an infant or something, they're laid on their side, like kind of prop them up. Like it's just kind of common sense. Gravity is going to be your friend from that standpoint. But obviously, we're going to look at the pharmacologic therapy being our mainstay. So. Certainly some of the things you can do from a lifestyle modification with their food. You can try to thicken up the infant's formula a little bit with things like rice cereal. However, sometimes you can find the exact opposite of that. I remember trying to give rice cereal to my first daughter, and that caused her to vomit like way more than without. So again, that could be one thing to watch out for. Sometimes they have any kind of food allergies that have been undiagnosed. Using a hypoallergenic formula can help with that. But certainly for older kids, avoid things like chocolate, caffeine, spicy foods. Usually not a big problem for young kids, but as they get a little bit older, avoid all the good stuff in life. Avoid that typically, and you'll be much healthier. So same drugs we're going to use here for these patients. Obviously, you don't worry about things like NSAID-induced ulcers, and a lot of them, unless they had some, they had like juvenile rheumatoid arthritis or something like that. But so most of the time, there's not really going to be an inciting cause like a drug that you can just discontinue to kind of help with this. However, a lot of the drugs we're going to use here are going to be very similar. Antacids, obviously, so I want to show some good examples of antacids. Calcium carbonate is a good one. What else? Sodium bicarb, probably used less commonly, but yes, that's another option. Aluminum hydroxide usually mixed with magnesium hydroxide, right? So remember, things like, which ones are causing diarrhea, constipation, because that can be a problem for them. So usually when we're given like the Malox, that is a mixture of the aluminum magnesium hydroxide, those usually kind of cancel out a little bit. Not unlikely to see a lot of constipation or diarrhea with that. However, the calcium carbonate especially can cause constipation, so be aware of that, especially if they already have issues with constipation to begin with, right? Less often we'll use some mucosal protectants. I probably see more Carafate than anything else being used. Definitely no sodium alginate for a lot of pediatric cases, but we'll use Carafate occasionally for some of these patients, usually in conjunction with something else. So again, if they're not really getting good enough therapy by themselves with like a PPI or an H2 blocker, we can add Carafate on. And again, Carafate is just doing what for us? Just kind of coats the stomach, kind of helps to kind of supplement that barrier a little bit better than it would be otherwise. So again, that is one thing we may add on. Now again, we have histamine H2 receptor antagonists. What are some good options there? Ranitidine, right, which is, what's the brand name for that? This is Zantac, right? So that's probably the most common one we're going to use. That one has an oral liquid formulation, so we use that one fairly commonly for a lot of our kids. The other ones, as far as I know, do not have any kind of oral solutions. So it may be difficult to get into some of those kids. So again, ranitidine is probably the most common one. Also, IV options are available as well. Zantac's been on shortage for a while, so now we're having to use a lot of Pepsid, which is, anyone know the generic for that? Yeah, it's famotidine. So that's a IV alternative we can use for some of those kids, especially if they're coming in, they're being admitted. And then our proton pump inhibitors, a lot of these have formulations that are, some that have like lansoprazole has like a oral disintegrating tablet that can be useful for some of these patients. A lot of them do not come in liquid formulations because a lot of them have to have that protection against the stomach acids. And so a lot of times what we have to do for kids in order to get this into them, we use omeprazole most commonly, like over at Nemours, and we actually have to take the little capsules out, put them into a mortar and pestle. We will crush them up and then actually mix it with sodium bicarbonate, and that sodium bicarbonate helps us start melt down on that protective barrier, and then we can stabilize it and administer to those kids. Again, probably losing some efficacy, but it can still get the job done in a lot of cases. So again, you have to think about formulations, think about which one's available in the liquid, because again, most kids are not able to take tablets until they're a little bit older. Some adults can't even take tablets, and they're very difficult to deal with because you're just like, come on, just grow up, just take a tablet. And you can't do it. The gag reflex is way too strong. But anywho, and there's some prokinetic agents. What are some examples of that? Yeah, Reglan or metoclopramide, good. That's acting on those motilin receptors. And what's the other one? Cinnamon is more like a stimulant laxative, but we're looking at prokinetic agents. Erythromycin is the other big ones. So think Reglan, metoclopramide, think erythromycin. Those are your two big kind of prokinetic agents in those cases. So again, we mentioned the antacids. Again, problem with those, they're typically very cheap. However, they need to be administered very frequently. Good for what sort of situations? Like really persistent, severe GERD. When are they better used? Intermittent, more episodic sort of GERD symptoms, especially if you know there's a specific trigger you can't really avoid. This would be a good option there. So again, most commonly use calcium carbonate or use mag and aluminum hydroxide. So Malox is a very common one. You guys ever heard like magic mouthwash or like a GI cocktail? These are some formulations that are frequently compounded with Malox. Again, because of this nice kind of, if a kid with like a lot of gastritis, things like that, we can usually use this, especially for the GI cocktails. We'll sometimes mix it with something like Benadryl, like viscous lidocaine, and then we'll sometimes use that for those kids to try to deal with something like gastritis. But mag and aluminum hydroxide is a common one we use as a base for that, essentially, because it does come as a liquid. And again, lots of drug interactions. Remember, it's going to bind up with other things. So if you have kids who are on a lot of different medications, this does need to be separated out. Otherwise, it may bind it up. Okay, mentioned mucosal protectants, Carafate. Again, this is a more common one. Again, it's good. It coats to the lower esophagus, coats the stomach. It's going to help to prevent that acid from really kind of interacting with the mucosa there. So again, very good agent. Usually used in combination with something else like an H2 blocker or a PPI. Right? Again, I don't need to belabor these points because you guys have already covered these already. So again, same things are going to go for this. Not a real big difference in side effects from adult to child. Prokinetic agents, these are actually good because they can help to increase that lower esophageal sphincter tone, that pressure, and maybe able to help some of that reflux happening and will stimulate peristalsis. What do you think is a big side effect associated with these though? Diarrhea, some abdominal cramping, things like that. So again, be aware of your side effects. Make sure you're educating on that. Again, two big ones are metoclopramide and erythromycin. Right? And with Reglan, what I worry about with especially like big dosing, long-term use. Yeah, we worry about extrapyramidal side effects, right? Because remember, it's blocking dopamine. So again, more often than not, I'll probably see most patients end up getting put on erythromycin because you don't have to worry about that. Because again, if you can kind of spare that dopamine, the chronic dopamine blocking effect for a long period of time, especially in kids, it's going to be better for them. So you may use this for like short-term use. However, erythromycin probably gets a lot more consistent use for prokinetic purposes, especially with a lot of our GI patients. Okay, we talked about that. Again, remember the drug interactions here. Remember, this is a CYP 3A4 inhibitor. 1A2 is less clinically relevant in a lot of cases, but the 3A4 is a big issue to watch out for. Let's see. All right, they're a histamine H2 receptor antagonists. Remember, they're blocking histamine. Now, typically, which one's more potent, your PPIs or H2 blockers? PPIs are always going to be more potent. However, these are cheaper typically. They've been over the counter for a longer period of time. So a lot of people have a lot of comfort using these. And so again, Zantac is probably the most common one since that gets used as an oral solution that's available. You can use that for a lot of kids. And which one do we never want to use? Cimetidine, because it's CYP 3A4. Fantastic. I probably will say that enough that if I ever see one of you guys ever using that in the real world, I will fail as a teacher and I'll say, nope, I'm hang on my hat and done with this. Time to go be a recluse in the woods. Doesn't that sound nice? Kind of awesome. I'm just kidding. I'll have a manifesto all right and everything. And I'm just kidding. You guys are probably too young to know the Unabomber. But anyway, all right. So proton pump inhibitors. Again, a lot of these are available from a dosage form standpoint. Again, sometimes we have to make special compounded solutions for these children, but so it can be more expensive, especially if you have to go to like a compounding pharmacy. And Anasoprozole is probably the most common one that will get used for pediatrics from an outpatient standpoint because it has that oral disintegrating formulations available. They can put it under their tongue and absorb it versus a lot of these other ones. If they can't take a capsule, then they're not really going to be able to absorb the drug that well, right? And there's some IV options available here as well. So we use things like pantoprazole, probably the most common one, but that's one we use most commonly. I think lansoprazole also has a form. We don't use it too frequently. Okay. So that's it for the GERD stuff. So again, very similar to treating an adult patient. You mostly just have to think about dosage forms, think about what's going to be appropriate for that patient. And again, look at other things that could be interacting. Look at drug interactions from like a antacid standpoint. These are things to consider. All right, constipation. What are we going to do for constipation for these kiddos? Use an enema. I heard someone mouth an enema. Change their diet. That's probably an easy one to do, right? But that's hard. Lifestyle changes are hard. I like my lifestyle. I don't want to change that. Just give me drugs. Words are hard. Yes, that's true. Math is also hard. Okay, but this is a very common thing. A lot of these kids end up kind of being chronically dehydrated, and that's probably where it's more of the issue than anything else. So yeah, their diet's probably pretty crummy. They're probably not getting enough water intake in a day, so that just kind of leads to having these very difficult to pass, very hard, dry stools, and so it's a big issue. We see a lot of kids coming into the ER, and do you need to really go to the ER for constipation? No, so it's a huge resource sink for a lot of these patients. If they had proper education, if they could get proper interventions where they would not need to do that, or if they could self-treat at home, that would lead to a lot of decreases in unnecessary ER visits, which would be a benefit. So anyway, so certainly there's going to be different varieties. So we can see like organic constipation related to things like CF or hypothyroidism, but in some cases it's going to be more functional. And it's going to be more common in a lot of these kids. When I say functional constipation, what does that mean? That term. Sometimes it could be related, sometimes they can have kind of a psychological component to it where they've had pain when trying to pass stools before. They become very hesitant to try to pass out again, right? Because they want to try to avoid pain. And so they can become very, a lot of abdominal distension, a lot of pain associated with that because, again, they don't want to poop, but they really need to poop. And this is one of the problems we run into a lot of these kids. And I mentioned my cousin who said, oh, my daughter's got the worst abdominal pain. She's dying. I'm like, she's constipated. And sure enough, that's what the problem was. But anyway, so certainly, find that the continence is usually maintained by both the involuntary sphincter, but more often the problem is going to be with the voluntary external sphincter. And again, we're going to see that the content of the stool is going to make a big difference here. So we can do things like to hydrate that stool, make it more easily passable by using things like emulsifiers. That's going to be beneficial to them and try to help them pass that a little bit easier. Now, see, normally with the normal frequency of bowel movements, first week of life, maybe 4 stools a day, could be even more common than that. Usually should be getting down to, by the time they're 2 to 4, anywhere between 1 to 2 stools a day. If it gets to be a couple of days without that, it's where you need to start getting concerned, especially if they're experiencing any abdominal pain. Probably need to do something about that. So, I never thought I'd ever be so interested in someone else's pooping patterns than with my children. So, of course, like, it'll usually be like a text between me and my wife daily, like, all right, Lily had to poop. Check. Because otherwise, if she doesn't, and I don't get that message, and I'm like, oh boy, it's going to shoot me cranky today. It's not going to be a good day when I come home. So, again, you may find that when you have children, you'll be very, very interested in their patterns. Anywho, so again, a lot of times you'll find that they have poor toilet training, they have poor diet, things like that. Like you can find a lot of pain and a lot of anxiety associated with constipation. That's when it becomes more of a functional issue for a lot of these kids. So again, we can try to change some of these things. Some of these things we're not going to be able to change, and so that's when we're going to have medications to kind of help us with that. Anywho, so certainly look to see, what's the family's definition of constipation. You need to make sure you're kind of in line with that. If they're like, oh, he hasn't had to poop for 1 day, and they're bringing him in for treatment, that's not really appropriate, right? So it needs to be at least several days. Looking for descriptions of the child's bowel movements, what's kind of normal for them versus abnormal, and looking at things like toileting behavior, etc. And certainly a physical exam will be very important here as well. So again, most constipation is going to be functional for these kids, especially with infants. You're going to find that if they have a failure to pass things like meconium, it could be related back to some of these disease states like cystic fibrosis, etc. You need to also consider whether or not the kid's breastfed or they're on formula, because with breastfeeding, you find more variability in the stool frequency. So again, trying to figure out what's constipation what's the definition of the family versus you. Make sure you kind of bring that in line. Usually in a lot of cases, especially with these infants, it just requires more reassurance, and things will kind of get into a better routine as they get a little bit older. Okay, so for treatment, we have several things we can do. Obviously, education is a big thing, but we're going to focus on the drugs. So we'll look at things for disimpaction, which we're going to be used for disimpaction, you think? Enemas are going to be a big thing. And also you think about things like your go lightlies, right? So those are going to be good for disimpactions. So again, we can either go via the mouth or we can go via the rectum, but there's ways we can get rid of that poop in a hurry. And then we'll find there's more kind of a maintenance therapy. So there's going to be things to try to help maintain good soft bowel movements once or twice a day. That's all we're kind of looking for in these cases. And again, a lot of this is going to be lifestyle change. Make sure they're eating good high fiber diets. Make sure they're getting enough water in their diet. Otherwise, this is where you run into these issues here. So looking at with fecal impaction, especially if they're coming in to the ER to see us, this is where the most common thing we're going to do. Because again, when people come to the ER, they want you to do something, right? They just want you to say like, well, just make sure they drink some more water and go on your way. They don't want that. They want you to actually do something, which is why a lot of people want prescriptions when they go to the ER, things like that. But they want you to get rid of that poo quick. And so this is where we're going to do things like some disimpaction here. Now we can do oral formulations, we can do rectal formulations. Sometimes we can use a combination of the two. A lot of times if we have kids who are very, very stopped up and they get admitted to the hospital for a bowel clean out, we will use both routes. We use both oral and rectal. A lot of times in the ER, if it's just kind of a simple constipation, we give them just a rectal route. Very, very quick way to get them cleaned out. But the oral route is beneficial because it's not invasive and it kind of gives a sense of power to the kids. So again, if they're old enough to kind of be cognizant of that, they're taking something and that's helping to deal with their constipation. It kind of gives them a little bit more power there. Versus when you're getting an enema, you're kind of powerless. You're kind of at the whim of whoever's administering it to you, right? Now with oral, you're going to find adherence to treatment can be a problem. So especially, make sure that the kid doesn't like the medication. They're trying to spit it out at you every time you give it. That could be a problem. So compliance can be an issue here. But rectal is going to be much faster. Big effects very quickly, but typically is more invasive, right? So again, you got to kind of know your audience. If you're dealing with like a 2-year-old who's constipated, enema might be totally appropriate versus if you're dealing with like a 16-year-old. The 16-year-old's going to want an enema. Probably not, right? So you have to have that conversation to kind of figure out what's going to be most appropriate for them. I knew this one doc who was like very old school, and he was just like, everyone's going to get an enema, whether they really come in for constipation or not. Everyone's going to get one. 18-year-olds, they're like, I'm fine. I don't have any abdominal pain. They're like, nope, you're getting one anyway. That's what it seemed like, at least. He must own like stock and fleets enemas or something like that, because the the frequency with which he went through it, that we would have to stock extra when we knew he was working those shifts. Okay, this is how serious it was. Anywho, so looking at the oral medications, we can use things like mineral oil, kind of an older school drug. We don't use this as frequently anymore, but nowadays we're using a lot of polyethylene glycol solutions. You guys remember what another brand name for that would be? Yeah, that's where we get our Mucolytics. This is where recommending like, okay, take 1 capful a day. It can be used for kind of normal maintenance of good stooling habits. But other things we can use, things like mag hydroxide, mag citrate. That's that milk of magnesia. Against that green rocket, will make you go really quick in a hurry. But other things, lactulose, sorbitol. You guys remember what senna is? The stimulant laxative, bisacodyl. It's also a stimulant, right? So those are both going to be stimulants. Remember, we like to use those for short durations because why? You can become dependent on those, right? So again, when you take those away, you can have kind of rebound constipation that occurs with that. So again, shorter courses are going to be better for this. A lot of things like mag citrate, those are going to be good for like just acute oral clean out, very quick, very not usually used for kind of more chronic cases. However, like something like Miralax, they can take that daily, just similar to like a normal fiber supplement. That's no problem. So for the rectal medications, we mentioned our fleet enemas. Those are sodium phosphate containing enemas. Now remember, who's that going to be a problem in? The elderly, but we're not talking about the elderly right now. So we're talking about little kids. Possibly renal, if they have renal issues, but more often than not, you can find that, especially if you're using kind of multiple enemas, which is why it's so important to ask what have they already tried if they come in to see you, because if they've already tried to give a Fleet's enema at home and they gave a really big dose there, and then all of a sudden you're giving them another one, they can see hyperphosphatemia, and there's been some deaths associated with that. So be very careful with, make sure you're using the right kind of dosing for this. I've seen them try to use a whole adult Fleet's enema in a kid who's like 2 or 3 years old, right? And that's just not appropriate. They need make sure you're dosing that appropriately for them. They have a pediatric size and they have an adult size. Just because it's pediatric size doesn't mean you have to use the whole thing. They can use half of that for really little kids, okay? So other things you can use like a soap suds enema, used occasionally. That's not recommended as much anymore due to some electrolyte shifts that happen there. They use tap water enemas, again, not recommended. More often than not, it's going to be saline enemas, phosphate-based enemas. Mineral oil is going to be fine. A lot of times we'll use a glycerin suppository, especially for infants. So they're less than 1 year of age. Usually use a glycerin suppository. That'll kick in pretty quick. It works very well for those kids. But bisacodyl as a stimulant also has an option here as well for rectal administration. So lots of options. Again, probably the Fleet's enema is the most commonly used for like really kind of quick acute evacuations in the ER. Okay, obviously make sure they intake a good amount of fluids, make sure they're drinking plenty of water. It's going to help to hydrate the stools, make it much easier to pass for the patients. Make sure they're getting, they kind of need some additional help. They can have some non-absorbable carbohydrates. This is where things like prune juice, apple juice can be very useful here. And make sure you're getting lots of fruits, whole grains, lots of fiber in their diet to help maintain kind of normal stooling habits. Obviously with behavior, make sure you kind of give them kind of unhurried time on the toilet after meals. You don't want to try to give them a complex about it, give them anxiety when they're on the toilet. So make sure you're trying to have good habits there. So it's all education points. And then for just daily treatment, this is where you're going to see probably most often that Miralax or polyethylene glycol is going to be used most frequently, in addition to things like normal fiber sort of supplements if the patient needs it. However, again, avoid kind of chronic stimulant laxatives as I mentioned earlier. You may need some kind of intermittent help every once in a while. Glycerin suppositories, all those are fine for short courses. Let's see. For infants, remember, especially depending on kind of where they're at in their diet, including things like those carbohydrates can probably be most beneficial, but glycerin suppositories are recommended. If they're less than 1, I avoid stimulants kind of altogether. Either use glycerin suppositories or some of these kind of fruit-based juices, things like that are going to be better for that age group. And that's it for Peds. So any questions? Again, never underestimate the value of a good poop. Mantra for life. All right, well, I guess I will let you guys go a little early, and then you have your review for Peds, and you guys will be set for tomorrow, right?